Hello, I am Mallika Shekhar, a haematologist in London, UK. Welcome to my podcast series called The Bitter Pill that looks at lessons that we doctors may learn from history. This podcast is called Decision Time. In 1983, there was a general acceptance that AIDS was caused by a virus and that it was transmitted by blood. At that time, most haemophilia patients in the developed world received factor concentrates to treat bleeding. Many had home treatment where they could inject intravenous concentrates as soon as a bleed was suspected. There were limited supplies of NHS factor concentrate produced from British blood donors, and therefore centres in England imported concentrates from USA. In the early 80s, typically, commercial imports comprised 60 to 70% of use. This raised concerns regarding safety because commercial concentrates relied on paid donors who were at greater risk for HIV at that time. This state of matters remained until heat treatment was introduced to inactivate HIV in plasma. This took time because heat treatment was being trialled for hepatitis C inactivation at that time and had to be adapted for HIV. So it was really not until 1985 when heat-treated products were implemented. It was also around that time when the significance of abnormal HIV results became generally accepted. That unlike the situation with hepatitis B, the antibodies were not protective. So in 1984, the doctor's choice was NHS versus commercial concentrate. These could be heat-treated or untreated, depending on the timeline through 1984. There was also the choice between using factor concentrate and cryoprecipitate. Cryoprecipitate was used to treat haemophilia before the advent of factor concentrate. Underpinning these choices of treatment was the fundamental value placed by the doctor and the patient on survival and, importantly, quality of life. In this podcast, we hear two doctors commenting on aspects of clinical decisions. The extracts are drawn from the YouTube recordings of evidence given under oath at the UK Infected Blood Inquiry. We will see how treatment options differed and why clinicians behaved differently when it came to treatment decisions. The episodes are titled Brexit, featuring Dr. Winter, and Rock Bottom, featuring Dr. Colvin. Brexit. Dr. Mark Winter started as a consultant haematologist at Kent and Canterbury Hospital in 1983. In early 84, he had to make some difficult decisions because HIV was affecting haemophilia patients via their treatment. There isn't enough NHS concentrate trickling through to his haemophilia centre in Margate. Reducing treatment or switching to cryo, he doesn't think are viable options. His patients, they have a view on what they wanted. His options are stark. He makes his choice, he discusses its pros and cons, and then tells us what happened next.
That there was so much of concern that we were already at that stage talking, the two of us, asking ourselves, can we get inactivated factor VIII? Because that's going to be the way forward. Well, as you've seen from the previous year, there was hardly any Elstree reaching Margate. The supplies were so limited. There was a feeling, of course, in the provinces that it all went into central London and that we were an afterthought.
You told the Penrose inquiry that patients didn't want to have American concentrate, and you say it took quite a bit of work to persuade patients in some cases to continue to receive commercial concentrate.
So now this is really now one of the next of a number of absolute key points in the epidemic. In my experience, the whole history was haemophilia patients from the moment of their diagnosis and growing up and going to meetings learnt that one of the sort of key things to follow was that people used to say to them in the Sunday morning meeting in a haemophilia society seminar in wherever, when you get back to your centre, you want to make sure that you get British factor VIII. Don't ever get American factor VIII. very early on in the haemophilia experience, the patient would have that message from somebody. It's a family illness, other people, a cousin or somebody, or an auntie might have said, you make sure all the patients knew, and in my experience, whether it's this period, January 84, or at a time a few months later when we're trying to persuade people to switch, people were very, very reluctant, completely understandably, they were right, to have factor VIII from commercial donors.
I'm really just interested in your use of the verb persuade. What was the reason why you were trying to persuade patients to do so?
Well, before the switch, because it was the only factor VIII I had, because I didn't have any Elstree, and as we've discussed, I didn't want to go back to cryoprecipitate.
You say this at this highly critical time. There were therefore only 3 options for haemophilia clinicians. So your option 1 was suspend treatment completely.
Yeah.
Your option 2 was to continue with BPL concentrate only. And your option 3 was to switch to heat-treated factor VIII and 9. Now, we know you opted for option 3. Just wanted to ask whether the position was truly as stark as you there set out, because presumably it wouldn't just be, you wouldn't have to suspend all treatment. You could reduce the amount of treatment, suggest, try and use a little bit more cryoprecipitate, give advice about management and bed rest, on a temporary basis at least. Was it a more nuanced set of options than this perhaps suggests?
No. Nobody ever gave bed rest to a person with haemophilia. They're bleeding and they need to have the bleeding stopped. With hepatitis C, we know you almost certainly got hepatitis C the first time you had a treatment. So the viral risk from one treatment might have been the same as from 30 treatments. So where was the logic in trying to reduce treatment? You were still going to give the treatment that had the virus. So there was no logic there. So it really did seem those, as a matter of strategic principle, those were the 3 core choices that lay in front of us.
And so could you then talk us through your reasoning for taking what was, I think, could fairly be characterised as a bold decision in the spring of 1984 to use heat-treated products?
Yes, this is one of the absolute key moments in the history of the epidemic. We'll have heard there was a certain view retrospectively from some people with haemophilia, why did I have to continue to have factor VIII? Couldn't I have stopped? Haemophilia clinicians like me were very unhappy about that suggestion. Cerebral bleeding has always been the most common cause of death in haemophilia. I think in that year there'd already been 10 deaths from cerebral bleeding in haemophilia. These are things, of course, the patients don't see unless it happens to their family relative. That's the sort of thing that the doctors see. The World Federation of Haemophilia have a twinning system, and every 2 years at the World Federation, a centre like ours from a developed world would get twinned with a developing centre. And we became twinned with Islamabad in Pakistan, who we went to see. They were nuclear power, but they had no factor VIII at all, nothing. And on the first day, we did a clinic for about 50 children, all of whom got carried in by their fathers, unable to walk. And at the end of the day, I said to the centre director from Islamabad, well, tomorrow, presumably, we can go and do a clinic at the adult centre. And he just looked at me and said, there isn't one. We don't need one. All of these children will die of bleeding. So the natural history of haemophilia, untreated, is to die of bleeding. So you'd never get a clinical doctor like me to sign up to a situation where I said to a patient, why don't you stop having factor VIII for a bit? Bleeding is a very, very serious issue. It's the most potent bleeding disorder known to man. So that was the easiest of the 3 options. It was absolutely not an option not to treat. So that was the easy bit. Now we come to the really hard bit. For years I reflected on this very difficult time and thought it was the hardest decision I ever had to make as a doctor.
In 1984, this decision point affected doctors worldwide. It was a moving point, a series of points. As evidence evolved, the choices had to be reappraised. Dr. Winter had a hierarchy of choices. The basis of his choice is what is in the best interest of his patient. In Islamabad, at that time, the overriding questions would have been what is affordable, what is available. Clinical decisions at that time were judged by the Bolam principles. Is your decision the same as that of a reasonable doctor?
For years, I reflected on this very difficult time and thought it was the hardest decision I ever had to make as a doctor. So let me just try and walk you through what the issues were. Firstly, we have the patients, British good, American bad. So the choice is, you can stay on British Factor VIII. It's from voluntary donated plasma, good. It's got a full product license, good. It's cheap, good. The patients like it, good. But there's no inactivation step. Surely you have to believe that this new virus, which it had been identified by then, and in mid-1983, French and then the American groups had identified the virus that we now know as HIV. So we knew that we were dealing with a virus. We just didn't have a test for it. So that was the big but. Did you believe, with increasing numbers of cases, still not very many, did you believe that the new virus would only be present in American Factor VIIIs, or could it be possibly there also in British Factor VIII? So that was the British choice. Or did you say to yourself, people with haemophilia are so vulnerable, the batches are from 20,000 donors. If one of those donors has a virus, the patient's likely to get it. They're incredibly vulnerable to any virus. Therefore, if I go for American, not liked by the patients, 50% more expensive, no license, but it's heated. Now, there was experimental evidence. The companies had started to bring in heat-treated Factor VIII to try and see if it inactivated hepatitis before anything was known about AIDS. So the companies in the US had started to work on heat inactivation. But that was the choice. So, and I sat down with the patients and said, I'm not happy about no treatment. This is a really, really difficult call. He thought we ought to switch, everybody. By February 1984, one of the companies, Alpha, they had a license in the US for the heat-treated product. That was a major step forward. And Dr. Savage and I approached them and said, we're aware of this license in the US. Do you think you'd be able to get supplies for us, which we would have to give on a named patient basis? So you understand, if a drug doesn't have a license, doctors in this country still have the ability to use a drug on a named patient basis. And the answer was, yes, we can. It's going to be 50% more expensive. So we decided that was the route we really ought to go down, because we were so very concerned that HIV, we now had a virus. We couldn't convince ourselves that it wasn't going to be in British Factor VIII as well as American, because of the intrinsic vulnerability of the system.
Dr. Winter makes a critical observation about the intrinsic vulnerability of the blood donation system. There was huge variation in donor practice across the world. Altruistic blood donors were a precious resource, and blood services felt reluctant to question them too closely. There was a tension between public health needs and the needs of the blood services and their donors. To donate without recompense was a sign of good citizenship and added intangible values to the donor as well as the blood services. Some liberal societies, for example, Netherlands, implemented donor self-exclusion, screening and selection more comfortably and more rapidly than others. Blood services the world over were reformed as an aftermath of these events with HIV. The other point of note is the practice of the commercial sector. They introduced stringent criteria for donor exclusions with less hesitation. But this was much later. They also distributed existing stocks of products that were less safe for commercial gain. In early 84, Dr. Winter and his mentor, Dr. Savage, managed to obtain this product for their patients. But not everybody agreed with their decision.
There was very widespread disagreement with those views. The arguments against were some people believed that this was a problem to do with commercial factor VIII. The whole virus story, non-A, non-B, HIV, it was commercial. Terrible donor practices. It was not going to happen to Britain with altruistic voluntary donors. This was an American problem. That was view number one. Secondly, the Germans always used huge amounts of factor VIII, much higher than Britain, from German donors. They had, apparently, they'd had little or no HIV. That was quoted. And then thirdly, there was a very understandable concern. We've spoken about inhibitors. About 10% of patients develop inhibitors, which makes the future treatment with factor VIII effectively impossible. And some doctors very reasonably said, I'm really worried about this because the heat treatment might alter the antigenic nature of factor VIII in the bottle, so that when it's injected into the patient, the antibodies, the patient's immune system might recognize the injection as being foreign for the first time and make an inhibitor. And this was a very serious, it would have been a very serious development, and it was perfectly reasonable to put up that as an argument. Having said all that and had this incredibly, I can't stress to you enough the difficulties and plus all the implementation of it, I had to persuade the patients who were anti-American. I had to, in the middle of a financial year, increase the budget by 50%. We had all the logistics of getting unheat-treated supplies in, getting heat-treated supplies out. So it was just in terms of logistics. Once you'd done that, it was very complicated. And you had other doctors saying to us at meetings, I don't know why you're doing this. So there was this, split up, probably in Britain, 20 major treaters. There was about, 4 to start off with, and then a few more, and a hard core of sort of 10 to 12 with a totally opposite view. So for the next few months, there is this complete, it's like Brexit, okay, just leavers and stayers. Anyway, finally, very poignantly, although for a long time I thought this was just the most unimaginably difficult decision, I now realise, and this is quite a powerful thing to say, actually it was all probably irrelevant, because I now realise that nearly all of the patients had already been infected. But anyway, that was the heat treatment dialogue.
You've described how difficult a decision it was. You've given credit to the arguments against that decision. Was there one factor in particular which made you decide the way you did, or not? And if so, what was it?
Well, I think the combination of these particular factors, I was totally sold up and had been since 1982 to the idea that AIDS was due to a transmissible agent. I then knew by the middle of 83 that was the case because the virus had been identified. I knew then that virus had been causing illness in a small number of American haemophiliacs, and by that stage a British haemophiliac. And I knew that the patients were incredibly vulnerable because they were receiving concentrate from thousands of donors. So if you added in all those little things, you had a pretty clear view. You had just lost confidence, if you ever had confidence, that concentrates were safe. And when historians in 50 years will write histories of haemophilia, they'll say concentrates brought unimaginable benefits to people with haemophilia for the first time. Home therapy, schools, work, exercise, etc., a normal life. But then a huge but. The Achilles heel. It came from thousands of blood donors. If there was a virus in town, in blood, the haemophiliacs would get it.
In this excerpt, we've heard how Dr. Winter made his choices. The choice of heat-treated imported factor concentrate was, to quote him, the hardest decision I had to make as a doctor. It was predicated on his belief that HIV caused AIDS, his acceptance that it was transmitted by blood, and his hope that it was inactivated by heat treatment, meaning the decisions were made on evidence and on judgment. He had collaborated with his peers, discussed it with his patients, negotiated with the commercial sector, and set the logistics in motion. The bigger picture that he raises is his view that the blood donation system was vulnerable by its very nature. The British donor pool is potentially infected, so the answer lay in pathogen inactivation. Unfortunately, despite his efforts, all his patients contracted AIDS. Let's now hear a different view from Dr. Colvin. Rock bottom. Dr. Brian Colvin started his consultant post at the Royal London Hospital in 1977. It's December 1984 now. We hear about his views on heat-treated products and his rationale for his choice of staying with the NHS product, even though he was not heat-treated.
But I recall December 84 very, very well indeed.
Under the heading Options in Probable Decreasing Order of Safety from AIDS for Haemophilia A, we've got heated UK concentrate as being the preferred option. Second option, single donor cryo or FFP. Third option, heated imported concentrate, still a non-A, non-B hepatitis risk. 4, unheated UK concentrate. 5, unheated imported concentrate. And the observation there is almost certain to be contaminated. Would you agree with me? That's a set of options where safety is now the fundamental criterion that's informing that.
So obviously it says probable decreasing order, so we don't know for certain.
No.
And I mean, I can remember this as if it was yesterday in December 84, when I sit in my office with my head in my hands talking to Peter Kernoff saying, what on earth do we do next? Because we'd reached really rock bottom in December 84 of our understanding and our power to deal with this crisis. And I think really from January 85 onwards, we began to address the problem and begin to get it right.
Now, you had unheat-treated products, and we still saw the letter that Council showed you earlier, where you said, in effect, that you were going to go on using up existing stock. Why exactly was it that you didn't do what you've accepted was perhaps the logical thing to do once it's been decided that a product is less safe than it might be? Why did you go on using it up rather than withdrawing it straight away?
So I think that the argument is based on my discussions with Peter Kernoff at the time, and that is that if it were to be the case that these commercial products which had been heat-treated were not safe from the HIV point of view, then all my HIV-negative patients would become HIV positive, and I'd have an even bigger crisis on my hands. And I mentioned this in terms of the decision that Mark made, and which I don't criticise, because he said himself it was the most difficult decision he'd probably ever made, and that was that he said that he was personally convinced that this was the right thing to do, but that conviction was based on zero evidence.
Dr. Colvin disagrees with Dr. Winter's decision. There are no data on the heat treatment. That shifts the entire balance. So he stays with the NHS factor concentrate, which at that time is not heat treated. He has done this after discussions with his mentor, Dr. Kernoff. In situations where evidence is still evolving and new technologies are possible, for example, the use of anti-inflammatory drugs in COVID-19 infections, institutions behave differently. Their choices are based on a mix of evidence, judgment, and hope.
Can I then go back to the period between May of 1984 when Mark Winter and Jeff Savage were going to use heat-treated commercial product. And that period between then and December, you still had a certain amount of factor 8 concentrate, which came from America, in use because you had to have. You didn't want it, but you had to have it to make sure there was supplies. Did you think that perhaps changing that to use heat-treated commercial concentrate would involve no greater a risk to the patients and might involve less?
I didn't know it existed.
But you didn't know about Mark Winter's decision at the time?
Not at all.
And
I don't think anybody else did either.
Well, it was quite interesting that you say that. Presumably there wasn't much discussion then around this time about the possibility of products becoming heat-treated. The reason I ask that is that it was in March '83 that Highland were licensed by the FDA in the States to distribute heat-treated factor 8.
But they were trying.
It's been around.
Yes, but they were trying
on that basis.
They were trying to produce a lower hepatitis risk product,
yes.
And I wasn't aware that such a treatment was available in the United Kingdom. And as I understand it, Mark's use of this product was based on his being provided with a supply which was enough for him and for Dr. Savage's use. But it wasn't available to anybody, and I don't believe that it was available to the nation as a whole in any way at all.
I just want to go back, if I may, to your description of why it is that you don't entirely agree with, or didn't agree at the time with, Dr. Winter's approach to heat-treated product. And what you said, I think, was you thought you would not use commercial heat-treated product because of three things. The three things you identified was, first of all, the donor pool, the way that the donor pool was selected. The second was the size of the pool. The third, I think, was the possible effects or side effects of viral inactivation. Considering the donor pool, the way selected, what was your impression of the donor pool from which the United States, certainly commercial concentrates, were drawn?
The point that I was making was that if the donor pool, as it was very highly infected with HIV infection, then it might not be possible to inactivate the HIV by the heat treatment method that had been chosen. Because the viral inactivation acts on a principle of log kill. That is, that you have logarithms of reduction. So if you have 10 to the 6th particles and your system of viral activation will deal with 10 to the 3rd particles, you're still left with 10 to the 3rd particles. And so it means that if you have a very high level of contamination, then a particular process of viral activation may not be effective because of the failure to address the number of logarithms of infection that are in that donor pool.
In this extract, Dr. Colvin explains his concerns over the heat-treated import. The efficacy of heat treatment to counter a large viral load was unproven. We are taught that uncertainty can be reduced to risk when the frequencies of outcomes are known. True uncertainty is present when we don't know the frequencies of outcomes. Dr. Colvin uses the existing data on HIV prevalence and the impact on his patients in a worst-case scenario should heat treatment have failed. The decisions taken by both the doctors, although they're very different, are examples of using available data to move from a stance of ignorance to uncertainty and then on to risk. In current practice, we are guided by evidence. Are we? A study from 2015 found that clinical decision-making in haemophilia is still based more on intuitive than on formal evidence. Decisions, especially when it came to changes in treatment, were based on past learning, previous experience, the influence of opinion leaders, of mentors, more so than the evidence from clinical trials. Trials were not, by most doctors, perceived to be directly relevant at patient level. The second point in this extract relates to how many people knew about this new product. The imported heat treatment concentrate used by Dr. Winter was not widely available. It was not widely known. Access to products on trial or early access to unlicensed products is an important matter for us in medicine. It helps us maximize our patients' chances. But how do we decide whether this is a safe thing to do? Is there equity, or is this down to personal contacts? Is equity desirable, or should early use of new drugs be restricted? And if so, what would determine this? We move to the next section with Dr. Colvin. How is a doctor to manage the clinical need of patients in the face of a serious problem with the supply chain? What, for example, if imports were disallowed?
How would you manage a service that was suddenly cut in half? And I think the answer is probably an abandonment of all surgery except absolutely life-saving surgery. And I think the abandonment of the home treatment program and a reversion to on-demand treatment only. And even with that, you might want to scale down the doses that you're using. Scaling down the doses perhaps for, and this could be controversial ethically, I haven't really thought about it through, but maybe you keep the doses for the little children the same and maybe sort of reduce the doses for the adults. I mean, I'm just purely speculating now in a very free way, and I'm not sure that what I'm saying necessarily makes sense, but I'm trying to think what one could have done. If you look at the position in India, Dr. Srivastava in Vellore for many years has done work on how to manage with a little bit of factor 8. And I've already explained to you, or discussed with you, the fact that if you give a little bit of factor 8, you get a massive bang for your buck, if you like. So that immediately, from nothing to a little bit, you get a fantastic benefit. And the benefit at the end is, well, significant, but, you know, it what makes the difference between somebody who's all right and fantastic, which is not the same as having somebody who's awful and surviving. So I think that if you had abandoned all surgery except for the most life-saving, and if you had abandoned the home treatment program, and if you had cut back on dosage and accepted a few deaths and some serious joint damage and some serious and very painful illness, you might have got away with it.
Yes. I'm not suggesting it would necessarily have been without consequences.
No,
I just wanted
but
to explore how it would be could be
share
done.
with you, just thinking about what you could conceivably do.
In this section, the discussion is about how one might cut down treatment targets, doses, and optimize regimens to a couple of notches lower. Dose regimens varied. In the early 80s, British dose ranges were lower than Norwegian doses. ELMIC dose ranges were even lower. The price to pay for low doses could be higher number of clinical events, more deaths. One way to modify this, if doses had to be reduced, was to change the lifestyle choices for patients. Would that be acceptable? In summary, this episode deals with the fundamental question: how do we make decisions about treatment in a situation where evidence evolves over months, even years? Death in haemophilia patients in Britain remained stable through this period in HIV-negative patients, but it rose tenfold in HIV-positive patients by 1992. These events of the 80s led to medical practice becoming more conscious of risk and averse to risk, the precautionary principle in current practice. The episode also touched upon the impact of decisions regarding blood donors and the changes that were brought about to blood services across the world. And lastly, it highlights the experiences of low and middle income countries. Learning is ideally bidirectional, and one of the examples highlights how prudence may be exercised in managing patients, but more poignantly, the significant gap in equity of access to life-saving drugs. Clinical matters have societal and political dimensions. Do our organizations enable global equity? Thank you for listening to this episode.